we get started, Tony? And if we finish early, everybody can get their time back.
For sure. I think this is the last of the sessions without our fellow. Our fellow's back from Ottawa, I think 2 weeks ago. So I think moving forward, we'll have him. So, I'm glad that I can talk to a small group of thrombosis peeps about this, because this is kind of like a kind of passion project side of my desk that I started a while back, and it's gotten a lot of attention from the administrator, and I'll explain why, but not so much from the thrombosis circle. So it'll be nice to get some feedback from you guys. When I say administrator, it's actually funded by STC, the Specialist Service Committee. They've actually funded my time to do this. And I also got some funding from St. Paul's Foundation, as well as the Department of Medicine. And I think it just because of the landscape nowadays that everyone's thinking about environmental health, I think that's why this project got so much traction. And I'm fortunate Taylor is helping me out. And for those of you working at VGH, you may remember Stephanie. She was a pharmacist at the BMT unit there, and we're fortunate to have her here at St. Paul's to run this program with us. And when I say traction, I actually got invited to talk to the Ministry of Health about this. I didn't know what to really say, but I think there's a real interest to clamp down on the carbon footprint of the healthcare system. And just last week, they asked me to include my work in the Cascade Playbook. Many of you may not know this. Cascade is actually a organization regarding planetary health or healthcare that's based in Toronto, but they actually collaborate with UBC, Dalhousie, and also I think one of the Quebec University. I've never heard of them, but it was actually fun to talk to them about it. So this was a problem that I identified, not just as a thrombosis physician, but as someone who does CTU as well. We know that there's this culture of prophylaxing people when they're in hospital, and it's almost to a point that whenever you step foot in a hospital, it doesn't matter who you are, there is an order, enoxaparin. And we know that while that's important, but there is a group of patients who probably does not need it, and the heparin itself is not harmless. So the ideal way of doing this is to get a risk assessment. People should get what they need. If you're low risk, you don't need it. If you're high risk, you need it. And we know that some people are super high risk, right? Like some more trauma patient, they need even a more intense anticoagulant for prophylaxis. So that's the problem that I identify, and a solution has already been identified, but I think there's a gap there. We're far from getting to the solution. St. Paul's Hospital went through accreditation last year, and that's why I was exposed to this. Because they came up to us in the thrombosis group and say, "Hey, there are some criteria that we need checked off." So I kind of went through this, and in my mind, I'm like, okay, many organizations will have a policy. I know VCH, St. Paul's PhD has it. I know Fraser has one as well. But I was just working through these criteria. I'm like, number 3. I would be very surprised if any hospital in BC has a process in place to monitor and audit the process, and also to use it for QI improvement. I don't think it exists in any hospital. And apart from having a team or stewardship team, I actually don't know how this process can be done. This is another reason why I started thinking about this project. Over here at VCH and PHC, we have this document. It was created back in 2014 or 15. And it was pretty clear that the evaluation of the risk is the first step. People need to be assessed in terms of the risk. And prescribing prophylaxis should be according to the risk level. And what I didn't realize that if the practice is deviating from the recommendation, the policy is that the physician should document the reason why. And I can tell you, as someone who works on CTU or other places, I've never seen that happen. I'm aware that there was some effort to update this document, because when we went through accreditation, the accreditor actually asked, "Hey, you have this old policy, it should be updated." Aggie, you may have been in the email chain, and I think made it to me and Anna as well. they wanted us to update the document, but they won't want to pay for our time, and it's a lot of work. So it's stalled, and on our accreditation report, this is they mark it as a pending item. So really, it should be done, but I unfortunately I don't see any motivation at this point for the hospital to do it. I randomly selected 3 patients admitted to CTU recently. Without a fail, our trainees have this little blurb at the end, housekeeping, full code status, DVT prophylaxis on heparin. It just reinforced how strong a culture it is that everyone does prophylaxis. I think it's been hammered into the trainees' head. It certainly was the case when I was a med student and resident. And there's no assessment. Everyone just reflexively checked off the box. While I was going through this problem, I kind of dug through, some of the more historical, policies, and I came across this. This was back in 2011. So for those who were practicing back then, you may remember this. The Canadian Patient Safety Institute came out with this starting kit, really to get more people prophylaxed. And you see all these steps here. And my understanding was this was basically distributed to every single hospital in Canada. And you have to do something similar to get some sort of check mark for, Canadian Patient Safety Institute. What really bugs me is this number here. Not just based on literature, but from anecdotal or personal experience, this is way overblown. And I don't think it's 10 to 26%. And if you go deeper, these are based on old numbers where they will do screening studies on patients. So everyone gets screening ultrasound. It's not that different from, early in the pandemic, where, in China and Italy, when the ICU got hit with COVID, they did these studies where they scan everyone's leg in the ICU, and, the DVT rate was like 40%. We know that this method likely really overblown the risk. So perhaps this number back then gave people a lot of fear and really pushed for this universal prophylaxis strategy. I put this together and presented to the Ministry of Health, and just to show them what is the impact of this strategy. I know it's going to help in reducing VT, but there's a lot of unintended consequences. From our patient perspective, hit is rare, but it does happen. There's bleeding complications, discomfort, injection, and nursing time demand. And likely we spend millions in BC in the hospital to pay for those enoxaparin 40 milligram syringes. I worked with our pharmacy department, went to the St. Paul's Hospital pharmacy database, the administrative database, pulled out the data, the cost data for enoxaparin 40 milligram syringes. In last 2022, we pay $279,000 just for that syringe. Likely the spending will be more because some of my patients will be on 30 milligrams, right? They're smaller, or they're on heparin because their renal function is poor. So this number is underestimated. We got some collaboration going on with a pharmacist in Fraser Health. He's also keen on looking into the system. He looked into RCH and Surrey and dug up the same data between those two hospitals. They spent $500,000 a year just on the enoxaparin 40 milligram syringes. And then lastly, the planetary health. I'll spend a few slides on it because I think that's why this has been picked up by a lot of administrators. In fact, I'm actually presenting another talk at the VCH PAC Planetary Health Committee just this afternoon at 6 p.m. So there's a lot of interest. It really stems from this, article not too long ago showing the estimated 1.1 billion pigs are used to meet the global demand of heparin. And we know that right now in most countries, except for certain Middle East countries, pig intestine is the only approved raw material for heparin. And it's not a very efficient process. One pig gives you about 1 kilogram of small intestine, gives you about 160 to 260 milligram crude heparin. And when you refine to low microheparin, likely you get 1 to 2 syringes. So not a very efficient process. And it is a black box. I've talked to a few of the reps. No one likes to share the process because it's an industrial secret, and rightfully so, because I think of the money involved. It's estimated to be billions of dollars of industry. If you look closer, sorry to be a bit graphic, I went to one of the animal science technology journal and just trying to get more information. In a proper lab, that's usually how it's done. You get the meat off the pig, get the organs. Usually they discard the respiratory tissues. You get the livers and intestine. Typically, they need to manually flip the intestine open, so the inside is actually exposed to outside, ground it up, separate it out, and then lots of chemical process goes into it. So it's a pretty involved process. This looks very organized because it's in one of the labs, I think in Europe, but in reality, it looks like this. Because most of the world's pigs are in China. I think estimated, 60 to 70% of the pig population is in China. And it makes sense if the raw material is mostly in China, most of the heparin is extracted in China. It's unfortunate when you have a rare material in a rural area. Often these people get exploited. Typically, it's a family-run small farms that do this work. Conditions not that great. But what really got my attention was, imagine the safety control, right? So much can happen in this process, and it makes me question sometimes, how secure is our drug? And we know that back in 2027, heparin crisis in the state because someone basically mixed in another material that is an anticoagulant that's cheaper than heparin, trying to make a profit, and at the end it killed a lot of people. So, and it makes me nervous. What products we're getting. As I alluded to before, it's a $10 billion industry, exceeding 10 billion just last year. It is expected to go up quite a bit. It is the second largest market of bioactive medication after insulin. And I think insulin is closer to about $30 billion a year, but the growth rate is not nearly as rapid as heparin, because with all those oral drugs. So perhaps one day heparin market will be even bigger than insulin. What I didn't realize, but now reading more about it, it clicked. The supply chain is a big deal, and we have one raw material that's basically required for heparin from a pig population, and we know that pig population can be exposed to virus, swine flu. So when that happens, the supply chain is affected. You get less supplies, the demand's only growing, and it makes sense that now it's driving up the price of heparin. Last year, Pfizer just announced that their heparin products will be increased 15% in price due to the demand issue. It also clicked with me that whenever I meet with a drug rep, very early on in the conversation, they like to say, we have no supply issues. We're all good. Our company doesn't rely on, heparins from China. It never really occurred to me why they want to mention that. Now I kind of know. Just for interest, both brand name dalteparin and tinzaparin gets all their pig source from Europe, so they're sort of insulated a bit from this supply chain issue. But still, it doesn't really secure the price, because if China's pig gets hit, that means pigs elsewhere gets, demand as well, so the price would go up. Versus all the biosimilar inox reps that I've talked to, including Equinox, the one that we use in our hospital, they source all the pigs from China. And part of the reason why they can drive down the price is it's cheaper. So enough of that, but this is why I kind of start this, little project outside my desk, because I think if done well, we can, reduce costs, reduce workload, improve patient safety, and also help the planet. This 3 Ps is a kind of the buzzword nowadays in corporate world. Think about private patient and planet. Obviously we don't make profits, but for us it's cost saving. What is anticoagulation stewardship? It's a system level designed to achieve optimal anticoagulation related outcomes and minimizing waste or drug effect. So it's really a system that we need to set up. So, I'm new to this, learning about it. So obviously I look around and Sunnybrook in Toronto is a pioneer in this area. I think people who I've talked to, I probably mentioned to you, they advertise themselves as a heparin-free hospital. Back in 2005 or 06, they started their Avoid Heparin initiative. They are focusing on unfractionated heparin mostly. I don't think we can reproduce this project in any way nowadays, because when you read into it, it's pretty extreme. I'm quite surprised that it actually went through. So what they did was overnight, their pharmacy department start substituting physicians' order without telling the physicians. It's kind of like if you order esomeprazole in hospital, they'll auto substitute to pantoprazole. So they did that. So if you order unfractionated heparin, they'll auto substitute you to low mercury heparin. They remove all the heparin flushes, only saline flushes. They even took out heparin infusion from order sets. So to order it, you really have to dig through and find a specific order. So it is pretty extreme. And except for ICU and cardiac ward, they actually took out all the heparin storage. You can't even find them. So they call this a natural experiment, but like really extreme, but very effective. I find this amazing here. This run chart really shows you the impact in terms of reducing hit. Low mercury heparin, the hit rate is pretty low. Most of our hit cases, at least the ones I see here are from heparin infusion in our cardiac patients. We do a lot of cardiac procedures. So right here, it's really dramatic decrease. To put them into more statistical perspective, in terms of hit with the double T, we talk about 90-something% reduction. That's pretty significant. And even with just suspected hit, people got a hit assay sent, because less people exposed to heparin, I suppose you're less likely to think of hit if they were never on heparin. So maybe that's why the suspected hit also reduced. Anyway, it was a dramatic improvement and sustained improvement as well. They also follow up to do a cost analysis. Again, this is quite a few years back. With inflation, our numbers will be different nowadays. But the hit-related healthcare costs before their program was $320,000. After the program is closer to $50,000, much lower cost. Other than Sunnybrook, we also have our colleagues in McGill, the Jewish General, who started the Anticoagulation Stewardship Program. They just started like maybe a few months before me, and their approach is actually quite different. So it was good to learn from them. Instead of focusing on unfractionated heparin or even prophylaxis, they focus on people with a therapeutic anticoagulation, all comers in the hospital. They have a pharmacist. Actually, they got 3. I don't know how they got the funding. They will systematically review any patient who had a therapeutic anticoagulation order. That can be from warfarin to DOAC to low mercury heparin. And using either thrombosis Canada guideline or CCS guideline for the cardiology indications to match the prescription and guideline indications. And if it does not match, they will call the MRP and recommend an adjustment. It's also very surprising. You're looking at almost like more than half of the patients they review, they were not on the optimal anticoagulation. There was some sort of an optimization that can be made. Well, that's a lot. And 80%, 84% of the time, the MRP actually accepts the recommendation. And as you can see, by far the most common reason why it was called is dose adjustment. I wonder, they didn't say in a lot of details, I wonder if a lot of the proportion of patients are on warfarin. I'm just wondering. Because you kind of think, why would you adjust the dose so often? But 13% of the time, they actually recommend some sort of lab test. So I'm curious. At the same time, I also wonder, why are so many people on warfarin? Because, you know, nowadays it's very few, especially in the hospital. Regardless, it's a program that I got some learning from. So with that in mind, we started our stewardship program and we focus on prophylaxis, as I alluded earlier. Is not a topic that the other systems or the other programs focus on, but I learned a lot from that process. Part of the reason that I want to focus on prophylaxis is the things I mentioned earlier. The second bit is actually more practical, because that to me was the only problem that has enough scale for me to achieve enough cost savings so the hospital will give me a pharmacist. Because at the end, no one's going to just have money lying around and give you a pharmacist. So with a bigger scope problem, I was able to draft up a business case to get the pharmacist. So that's partly the reason as well. That was my aim, the project, to increase the adherence of guideline-directed prophylaxis prescribing, and in turn to reduce heparin usage by 20% in 6 months in hospital. And why that 20%? It really based on our baseline sort of environmental screening. A fellow helped me with this from June to October of last year. We basically took I should say 2022, we randomly, using the Cerner functions, randomly selected 100 CT admissions and basically audit the VT prophylaxis practice. So the fellow did it for us. We used this framework, which was done by a previous program, where we follow the flow and the flow of the order, like what are the workflow of giving prophylaxis order, and also the areas or the steps that's something, or how should I say, I would say inappropriate, something that can happen that will lead to a failure to follow the guideline. It starts with people actually assessing the risks. So we went through all the admission notes, and not to our surprise, only about 10 to 11% of the time people actually documented assessment. Most times there's no VT assessment. And then our next step is we do have safety nets in terms of Cerner prophylaxis order. It's actually a PowerPoint that people put a lot of time to put it together. It is linked on Cerner. During admission, people are supposed to use it. And we found that 43% of the time they don't even use it, let alone using it and just blindly clicking it. And at the end, it led to about 24% of the time that patients don't get the guideline recommended prophylaxis. Most of these cases are actually people who are low risk being prescribed. There were a few high risk patients who were on inappropriate dose. You know, they're larger patients, but they're getting insufficient dose. We know that there are other steps in the chain that can affect the outcome. For example, did the nursing staff give it? Did the patient refuse it? And did people reassess the VT risk, which is recommended by our policy when you switch from a certain level of care to another level of care? For example, transferring from ICU to the ward, transferring from medicine to a surgical unit because the patient had a surgical emergency. We thought about that in retrospect, so we actually didn't look at the data in that aspect. Just to remind everyone, this was put together by Aggie and Karen when Cerner came on. This is actually attached to our admission orders. There is a little blurb or a warning that people should click and go through this whenever a patient is admitted. But again, it's not like a hard stop function on Cerner, so you can easily just skip it. But it is there. The improved score is what we decided to use in our institution, in our health authority. And also, to my understanding, it's also used in Fraser as well. We set up our stewardship program workflow quite closely to our antimicrobial stewardship colleagues. And also we now have an opioid stewardship team as well. Basically, it's the same structure. We generate a list of people admitted every Monday, Wednesday, Friday. The pharmacist will go through them using the improved score and audit the VTE risk. And then she looks at the prophylaxis order by the team. If there is a mismatch, we'll give the MRP a call and give our recommendations. Again, we're not changing orders. We essentially doing what the antimicrobial stewardship does. We suggest stopping potato. That's what they do. For us would be we suggest this for PVT prophylaxis. On top of that, we are doing monthly teaching sessions for mostly medicine physicians, resident and med students. And the morning report actually gave us a perfect, platform because everyone needs to be there. So we just go to the morning report at the first, I think, second Monday of the month. So we're always there and try to remind people. So I'll show you some of our results in the last 6 months, and it's actually very interesting. We looked at how much, what's the proportion of patients, a low-risk patient who are inappropriately given prophylaxis, because we deem those people as low risk. In the beginning, it's actually much higher than I thought. When we did the baseline scan, it's closer to 25%, but when we start doing it, it's like 40%. And you see these variations. It actually coincides with the new group of residents, right? Because every month, there's a new group of residents, new group of med students. So we have to repeat the message. So we can't really keep the trend going down. It just bobs back and forth. Hopefully, when we do it long enough, the R1s, by the time we get to R2, they will know. But I know yet to see. What about the high-risk patients? I also want to know. So I thought it would be closer to 100%, but it's not. So it's still a group of high-risk patients who are not on appropriate prophylaxis. Now, I did this. This does not mean that they're on nothing. It often means that they're not on the appropriate dose or renal dose. We also consider heparin to be quote-unquote inappropriate if you have good renal function, because we know is less efficacious, also higher risk for HIP. So if we add those together, there's actually a 20% room that we can improve. And we also track how often people actually accepted our recommendations. And you can see when we started, it's like 60% people are very skeptical at the beginning. Often we'll call them on the phone. They're like, okay, I'm just doing what I think is right. I've been doing this for 30 years and I'm not changing. So with education, we're getting better, so nowadays it's closer to 75, 80% of the time people actually will say, hey, okay, we've seen some of the data you present, we'll agree. In the 6 months, we did 889 audits. It generated 235 recommendations. So about a quarter of our audits resulted in some sort of recommendation. So it means that 25% of the time, these patients can be optimized. These are a breakdown of what our recommendations were. By far, the most often common recommendations are actually deprescribing. These are low-risk people who were put on prophylaxis. About 20% of the time is actually initiated. I thought this would be lower, still there. Dose adjustment usually are people who are heavier, but they're not on the sufficient dose. And then also switching to unfractionated heparin to low microheparin when the kidney's fine. Now everyone's waiting for this. I was very worried will cause a lot of DVT, obviously, so we're quite diligent in tracking it. To my surprise, with all those presentation with the Ministry and Health Authority, not a single administrator asked me this. All they care was the money. But for physician group, I know this is extremely important. We're a little bit delayed because we need to wait 3 months after the point to get our 3 months VTE rate. So this is only the first 3 months data. So in the first 3 months, we took 63 people off prophylaxis, low-risk patients. There were 169 patients after our education. the physician properly did not prescribe him. So we had 232 patients, low risk by improved score criteria. I got 2 students who were doing chart review with us. Thank God, it's a lot to go through the chart reviews. The VTE rate in 30 days was 0.4, so one of them. If we stretch it out to 90 days, it becomes 1.7%. So, is this a comfortable level for people to move forward? So far, talking to the medicine colleagues, people seems to be comfortable. I do want to bring out a key point though. We dig deeper and see why these 4 people came back with clots, and there's a trend. Most people get a clot because they're readmitted for another reason and then develop clots. So it was the first patient actually got readmitted to CCU with cardiac issues. While in CCU, they developed the DVT. There was a patient who got readmitted, I think 2 or 3 months after discharge from medicine, to a surgery ward for it was appendicitis, and got a DVT after the surgery. The third patient actually presented back to the ED, found out a typical St. Paul's population, overdosed, and found to have a PE at the same time. And then the 4th patient got readmitted to ICU for severe sepsis and got a DVT while in ICU. So to me, it's a little more reassurance, because I think in a lot of these cases, the prophylaxis during the index hospitalization will probably not prevent the event. You can argue that the 3rd patient, perhaps, if they were on something during the index event, we could have prevented something. Ben, I see your hand up.
With this second presentation and readmission, using your algorithm, would they have been put on prophylaxis this second time around?
Yeah, it's the second time, because improved score is not validated for surgical patient. So this patient is actually on prophylaxis while they were admitted for surgery. Yeah, but obviously it's not an improved score type of patient population. The patient who got admitted to CCU actually was not on prophylaxis in CCU because she had a heparin. They have the drain out bloody fusion, so obviously she was not on it. The 4th patient was on prophylaxis while in ICU. So what about our high-risk patients? So I was curious to find out this, just to get a sense of what is the VTE risk in our whole population in the hospital. In the first 3 months, we had 156 high-risk population. I took out people who were put on therapeutic anticoagulation for whatever reason in hospital, or people who were put on any sort of oral anticoagulant. So we left with 156 high-risk patients who were on prophylactic dose low microheparin. I was a little surprised how many people got breakthrough. So 7 people had a breakthrough clot. They all happened within 30 days, actually. When I stretched it out to 90 days, it didn't increase. It all happened in the first 30 days. So that comes to about 4.5% of breakthrough prophylaxis. And these patients were all on quote-unquote optimal prophylaxis, because the stewardship program, we actually screen the patient and make sure they were on the right dose for the weight. So a little higher than I thought. Maybe worthwhile thinking about that in the future, like whether we can even optimize this group. There is a parallel process that we use to de-prescribe the ALC. For those who are not familiar, ALC stands for alternate level of care, meaning these patients are no longer acute. They're in hospital because of disposition issues. We decided in a group that we'll use something straightforward. Whenever someone switches to ALC, or if they have been in the hospital for more than 4 weeks, we will screen them. If their acute medical illness has resolved, if there's no surgical indication, for example, hip fracture or hip replacement or cancer surgery, and if they've received at least 14 days of prophylaxis in hospital and no prior history of active cancer and VTE, we will call the MRP and say, hey, we think the patient can be prescribed. It's a lot more challenging because we don't have a strong guideline to back us up, but we felt like that was the right thing to do. And to our surprise, this was actually much easier than people who came in with acute illness. Most people are actually quite happy to take them off. It got to a point that we have a regular meeting with the geriatrics NP. We meet with her like every Wednesday before lunchtime, and we'll just run through the ALCs, and every time we de-prescribe quite a few people. So it's been quite smooth. Remember I talked about Cascade, this coalition that formed in Toronto? I talked to some of their members, and this actually came from, I think, Toronto General. One of their groups decided they would use this, and it was actually more complex than what we are choosing to use, but it's similar. So for them, if the patient meets this requirement, they will actually de-prescribe prophylaxis in hospital. Whether the patient is moving a lot. We thought it was a hard metric to capture, so we actually didn't use mobility because it's hard to tell when someone's in hospital. They also look at a list of other things that if the patient has 2 or more of those, they'll keep them. Again, these are not study-based, it's expert consensus in a single center. I'm happy to see that some other sites are doing this as well. So what about the ALC? In the first 3 months, we de-prescribed 60. Some of these people stay in hospital for like 4 months. If we don't de-prescribe them, they're on injection for a whole 4 months. Out of the 60 people, one of them had a DVT. It was a patient who got discharged, got readmitted to actually medicine for sepsis 2-3 months later, and got a DVT while during that admission. So there's a trend here. Most of these people get clots because they get readmitted for another medical condition. So those are what really, we care a lot about in terms of data. But this slide is what got so much attention from the health authority. I call it the money shot, because we basically reduced the spending on heparin prophylaxis by 50%, in the last 6 months. And if you stretch this out a year, it actually more than pay for our pharmacists. So they, recently just told me, now I have permanent funding, so we have that pharmacist book it, don't need to worry about losing funding. How about we kind of translate it away from money, because money is good to have cost savings, but I think there are other metrics that are important for our patients. I also learned that I'm not allowed to share with anyone outside of St. Paul's Hospital or PHC how much St. Paul's is paying for the enox syringe. Apparently, it's a pharmacy secret. I got my mouth slapped because I said it once, so what I'm not allowed to say. But rounding off the number, we end up reducing about 1,200 syringes every fiscal period. So every month we save 1,200 injections. That's about 110 nursing hours. I don't know how much bleeding will reduce. Probably very small, because we know prophylaxis doesn't really increase bleeding that much. From our very rough estimation, that's about 7,000 kilograms of CO2 equivalent prevented for fiscal period. Putting things into perspective, that was the slide that I kind of pitched to at the end to our finance committee. That was our expense for our 0.5 pharmacists, and here are the cost savings. It was very interesting to put this here. It was from the Sunnybrook study. They're saying that each hit will cost the hospital, $34,000. That was like 10 years ago. I'm sure it's much more expensive now. Gastroband's always in shortage. I'm sure it's expensive. I'm pretty sure it's more expensive. So I'm just gonna put it here to kind of let the administrators know it's not just about nursing hours and stuff like that. It's also the cost of caring for complication that we may trigger. This was an unexpected finding. I want to keep our nursing staff happy as well, because without their support, this program won't run. This is probably a big problem, mostly in St. Paul's, but I imagine to a certain extent other hospitals as well. while I was running the program, the nursing leader actually came up and said, hey, we had an incident report because a nurse got punched by a drug user at the hospital because she was trying to give prophylaxis. So this somewhat gave us advantage because it became a sort of like we're allies with the nursing now. We're working in reducing these risky, potentially violent situations. So I surveyed all the nurses on the medicine floor. We have about 100 nurses that rotates to. 23 of them answered the survey. It's pretty shocking, right? Close to 90% of them had a close violent interaction while giving prophylaxis. Again, I'm sure it's not that bad in another hospital, but if you ever work at St. Paul's, it's not alarm and not surprising. So what's next? I really want to tackle heparin infusion. I think to many of us, this is a pain. I really want to learn from Sunnybrook and see if we want to make it better. So the first step was I got my med student to do a baseline scan, and I want to share some of the interesting finds. I think it may translate a bit different hospital. So we went to Cerner and basically pull out every single patient in 1 year period who had an order for unfractionated heparin protocol, including both standard and low target. So there were only 70, so lower than I thought. But we excluded so on Cerner, you can actually exclude your data by geography. So we excluded the 5th floor in St. Paul's, which is cardiology. We excluded the 3rd floor, which is ICU, CCU, cardiac surgery. So we include 6 floors on, so that is renal, medicine, ID, geriatric surgery, and palliative care. But still, 70 is actually lower than I thought, 70 patients. In total, we used 747 bags of heparin. And again, I can't tell you how much each bag costs, but rounding off the number, that's about $12,000. For managing these heparin protocol, about 1,500 PTTs were ordered. Each PTT, it's actually $14 in the hospital. So that comes to about $20,000. Estimate nursing hours, about 130 hours. I got this number from actually a Toronto group that published in the Canadian Journal of Hospital Pharmacy. They actually got the nursing staff to carry like a beeper and measure the time that they spend in every single task, like putting that with the IV, looking at the nomogram, calling the physician, and how much hour that they spend in each day doing the heparin protocol. Using that, our estimate is that it's about 130 nursing hours. So overall, it's actually a smaller, I wouldn't say issue, but a smaller scope problem than I thought. I thought more people would get heparin. What about the indications? By far, the most common acute indication to be on heparin hospital, at least in our group, was VTE. To me, that's significant because I know the literature for ischemic limb or mechanical valve less, but for VTE, to me, there's really no situation, almost no situation where you put someone on fractional heparin. Maybe when you're in ICU, one of the lights, but really it's an inferior drug for efficacy, it's higher bleeding rate. So it also tells me that we have a lot of room to improve. Obviously, a lot of those patients were on heparin for ischemic limb. We have a pretty good working relationship with our vascular surgeons, so perhaps we can work on it in the future and see if we can make things better. Now, this can be very helpful as well, because to me, if you're a patient with reasonable renal function, we have a lot of options. Even if your clearance is less than 20, I think we are getting more and more experience with using PINZA and measuring antithymia. So it tells me that we have a lot of room to improve these patients by switching them to low microheparin. Now, I don't think this is a surprise to anyone, but I'm actually love to show this to our CTU or medicine colleagues, which I will in the next CTU meeting. If you're on the medicine board, if you're put on an unfractionated heparin infusion, 40% of the time, you'll be super therapeutic. 21% of the time, I mean, subtherapeutic. 21% of the time, you'll be super therapeutic. Less than 40% of the time, you're actually on target. You're talking about a medicine ward that doesn't get the ICU level of service in terms of blood tests. When you order it, sometimes it takes hours to get blood tests. You have a nurse who's assigned to 5 patients. They're all high demand. They're super busy. It's not a surprise that the TTR is bad. And our nursing staff on medicine floor is very green. Whenever they experience, they go to somewhere that is better environment, right? So they're all very junior nurses. Oftentimes, they only will do the heparin protocol twice a year. Super inexperienced. So not surprising at all to me, but I would love to show this to other physicians because hopefully that is an incentive for the people to switch over. Now, this actually caught most of my attention. I am very keen to hear what you guys think because this actually really bugged me. Out of the 70 people that were on fractional heparin, when we reviewed it, 13% of them had a major bleeding event in hospital, ISTH definition. Out of the 13 people who bled, 6 of them were on vascular surgery, 5 on medicine, 2 on nephro. Chart review, obviously, we know that we likely underestimate, right? Because we're based on the discharge summary, we're based on the transfusion record, we're based on the OR notes. But that to me is shocking. You know, almost 20% of people, when we put on heparin, they bleed. The other shocking part is I cannot remember the last time I ordered protamine, but out of the 70 people, 6 of them had protamine ordered. 4 of them ordered intraoperatively. All of them happened, actually 3 of them was in a vascular surgery OR. 1 of them got ordered in a cardiology or cardiac surgery OR. And 2 people got protamine order on a medicine ward. I'm like, I can't even remember the last time I ordered. So this was a bit shocking to me. Anyway, so that's our environmental scan. We love to tackle this problem. So if there's any suggestions, recommendations, advice on how we can approach this, I'll be happy to do it. We're fortunate that we have permanent funding to our pharmacists. So we're going to slowly spend less time on prophylaxis now that it's on track. We'll try to tackle the heparin problem. So with that, I'll stop here and happy to hear what you guys think.